All right, so welcome everybody. Thanks for joining. The CE code is here, and I hope everybody had a good Thanksgiving. It's nice here. I'm visiting my in-laws in New Jersey, so I'm a few hours ahead of you guys. Um, but this month we're going to be talking about pneumothorax and specifically tension pneumothorax and needle decompression and some of the common pitfalls and issues that you can run into. And we are going to get a little bit into the weeds, hence the photo. So bear with me, but we're going to start as usual with a couple of cases. First, before we dive into our first case, I like to start out with just updates about what's happening in the system. And you'll notice that we haven't had any very recent protocol updates, but we are going to be putting out our behavioral health policy update for comment soon. And then really our first quarter of next year is when we're gonna come out with our sort of release of new protocols for the next round. So we're looking at behavioral health, we're looking at childbirth and anaphylaxis allergic reaction, and probably a number of others. So it'll probably be a bigger update coming in early next year. So just that's kind of what's on the horizon with the holidays and stuff. Things have been slowed down a little bit. And but we'll be picking back up with a lot of new stuff coming early next year. So the CE code will be up at the end as well if you didn't catch it yet. Um, so we're going to start with a case. So this is a 30-year-old patient that was hit by an SUV at an undetermined speed. Patient was actually lying in the middle of the road, and a bystander was calling from up in their apartment, and they actually watched the patient get run over. So probably not possibly run over, definitely run over. The blood pressure you can see here is a little bit borderline. They weren't able to get a readable SpO2, but the patient is quite altered and sick. So he's got some, obvious musculoskeletal injuries on top of everything else. This was a system where they were able to give whole blood in the field. So this patient, because of his low blood pressure, received whole blood, was intubated, ended up receiving a needle thoracostomy in the left chest because of decreased breath sounds. And on repeat, the vitals were a little bit better, but still hypoxic. And the patient was transported to the local trauma center. So we'll come back to the case at the end and let you know kind of what was actually going on with the patient. But first, we're going to go on a little detour into pneumothoraces and tension pneumothorax. So, pneumothorax is actually a really common clinical entity. I think everybody on this call is aware of what a pneumothorax is, right? Air in the pleural space. Um, it's present in about 20% of major trauma. So, we're talking like blunt multisystem trauma. Tension pneumothorax is much less common, but still present about 1 to 3% of the time in patients with severe trauma. Um, when we look at the cause, you can have medical causes for tension pneumothorax. And so the vast majority of tension pneumothoraces are going to be due to trauma. So anywhere from, 99% or so, even, maybe a little bit more in some systems, but are going to be due to trauma. But there are certain medical conditions that can certainly cause pneumothorax, and you guys are all aware of spontaneous pneumothoraces, and there are genetic problems that can predispose you to that, or things like COPD or certain kinds of lung infections can predispose you to a medical pneumothorax. But the vast majority of the time, these are going to be due to trauma. And we define tension pneumothorax, and I think you guys are all aware of this as well. What we define it as in our system is a pneumothorax with hypotension and severe respiratory distress, essentially. So basically, you have a lateralizing exam with decreased breath sounds with hypotension and respiratory distress. But if you really look at the literature, there are all sorts of definitions out there, and it's really not that straightforward. Tension pneumothorax is a very difficult thing to study because typically it's a clinical diagnosis, and it's a clinical diagnosis that we're treating immediately in the field. So how do you know which patients truly had a tension pneumothorax? There have been a multitude of studies that have looked at vital sign abnormalities and how these patients present, and we'll dig into that a little bit more. But it actually isn't as straightforward as the definition that we use. There are certainly a subset of patients that have tension physiology who don't have hypotension, who just have respiratory failure. So you'll see different definitions in the literature. Kind of one definition that a lot of people agree on is that it's a life-threatening respiratory failure or hypotension in the setting of pneumothorax. Another commonly used definition in the sense of like when you're doing a study and looking at it retrospectively, is you have a patient with a known pneumothorax who has hemodynamic compromise or respiratory distress that gets better with needle decompression. So those are some of the definitions that are used. So how do these patients present? They can have a multitude of vital sign derangements, but most commonly, hypotension and hypoxemia are the two that have been associated with tension physiology. We all learn about, this jugular venous distension or tracheal deviation or subcutaneous emphysema as being signs, and certainly you can see those things, but JVD and tracheal deviation are very late signs and pretty uncommon. So you typically won't see those things. And then subcutaneous emphysema, while that can tell you probably have a pneumothorax, it certainly doesn't indicate that you have a tension pneumothorax. So may or may not see that. So um, we'll talk about the role of spontaneous respiration in this versus patients who are mechanically ventilated or have positive pressure ventilation, because those patients will actually present a little bit differently. But hypotension and hypoxemia are the only vital sign derangements that are shown to be associated with tension pneumothorax. And so when you think about kind of what's happening with a tension pneumothorax, right, you have air entry into the pleural space. If you are spontaneously breathing, meaning you're breathing on your own, um, you're able to compensate, right? You can compensate your respiratory rate. You can compensate your tidal volume. You can actually, subconsciously, you are compensating by, having negative excursion of the contralateral chest wall. So you can do all of these things to compensate. And those patients tend to maintain their blood pressure longer. So patients who are spontaneously breathing may not have that hypotension as their initial presentation, but they still have that tension physiology where the heart is being compressed by that air in the pleural space. And so in patients with spontaneous respiration, there have been studies that have shown that death in these patients or decompensation in these patients is more likely due to progressive respiratory failure rather than true hemodynamic collapse. So if you contrast that to patients who are being mechanically ventilated, and if you think about this, right, if you're spontaneously breathing, the only time that you're introducing air into that pleural space is during inspiration. But if you have a patient that is being mechanically ventilated or have positive pressure ventilation, you are, particularly patients on a ventilator, which is less of an issue in the pre-hospital setting, but you are introducing air continuously into that pleural space. So those patients are going to progress to that cardiovascular collapse much more quickly and be much more likely to have hypotension, because they get more and more pressure on the heart. And that's in contrast to patients who are spontaneously breathing. Their time of progression to decompensation is going to be much longer, typically. Now, that's not to say that we can't have a patient that very rapidly decompensates in the pre-hospital setting if they're really sick, but it's much more likely that it's the patients who you're ventilating. You're introducing positive pressure ventilation that are going to decompensate more quickly. So hypotension and mortality are much more likely in those patients who are being ventilated. And this is a consideration, if you have a patient who's intubated, just to be aware that you should be ready to decompress that chest if you suspect there's a pneumothorax, because they very well may progress to tension physiology. So just something to be aware of. Um, so this is the same study, and they basically looked at spontaneously breathing patients versus mechanically ventilated patients, and the assisted ventilations, the positive pressure ventilation patients are in the gray. And you can see that if you look at their systolic blood pressure, you have blood pressure charted here on the y-axis. Their blood pressure, their MAP is significantly lower than those patients who are just breathing spontaneously. On the right here, this is really interesting. They looked at the time to development of hypotension or cardiac arrest in patients who were breathing spontaneously versus those who were mechanically ventilated, or assisted ventilation, um, in patients who had known pneumothorax and tension pneumothorax. And you can see that in the ventilated patients, they are much more likely to develop sudden decompensation. So within the first 0 to 5 minutes of onset, developing hypotension or cardiac arrest. So they're going to do worse, and they're going to do worse more quickly is the bottom line. And so indications for needle thoracostomy, at least in our system, and this is fairly universal, or you see this in a lot of systems, suspected tension pneumothorax, traumatic cardiac arrest, and then PEA arrest with suspected tension pneumothorax. Um, And I will say that medical arrest due to tension pneumothorax is exceedingly rare. And so I think there was a period of time in EMS where a lot of patients who had a medical arrest would get needle thoracostomy. That is not really happening so much anymore. It's very, very uncommon as a cause for a medical cause for cardiac arrest. And so this is sort of adapted from the NAMSP guidelines. They put out some guidelines last year around needle decompression, around identification of tension pneumothorax. And so this is kind of their guidelines, simplified in a much simpler format. But basically, you have a high energy mechanism or penetrating trauma to the neck, chest, or abdomen, along with persistent shock, despite whatever efforts to control external hemorrhage. And then you have these red flags like decreased breath sounds on one side, respiratory distress with hypoxia, and then to a lesser extent, subcutaneous emphysema and tracheal deviation. And then I put a note in here as and we're going to have a case later on where this occurs, but you have a patient that you just intubate and then they develop decreased breath sounds. How do you know whether that is a right main stem intubation versus a developing tension pneumothorax? The truth of the matter is you don't, but you just have to remember that consider main stem intubation as a cause for decreased breath sounds because, or decompensation, because that definitely happens and it sort of, people can get focused on this idea that the patient has trauma, they might have a pneumothorax. And the simplest fix, and I've actually once had this as a case in the hospital as a resident with a different patient on the floor, but the patient had been intubated. Everybody was freaking out because they had decreased breath sounds, they were hypoxic, they were ready to like put in a chest tube and do all these things. And really, the patient was just a main stem intubation and just needed to have their tube pulled back a little bit. So don't get fooled by that, is the long and short of it. There are a couple of absolute contraindications for needle thoracostomy. One of those is a gastrothorax. And so what that is you have a traumatic diaphragmatic injury where the diaphragm is ruptured, and that causes the abdominal contents to get pushed into the chest cavity. And you can imagine that if you do a needle thoracostomy, and this is an example of this on the left-hand side here. So the left hemidiaphragm is significantly raised up, and this is your stomach in the chest wall. So if you put a needle into that, you are going to cause significant damage, penetrating injury now to the stomach and stomach contents in the chest wall, which is really, really bad, as you can imagine. Um, in patients with COPD, they can develop blebs, which can be confused for a pneumothorax. And this is really not a pneumothorax. And this is basically just kind of like a contained, um, it's not a pneumothorax, but they just get breakdown of the walls of their pleura, and you get these big giant blebs. Very easy to confuse for a pneumothorax. That's a relative contraindication. You're not going to know this in the pre-hospital setting, but if you know a patient has COPD, you might expect that that could be a potential in those patients. And there are certainly a lot of pitfalls when it comes to needle thoracostomy. And this has been studied over and over, and it's not just a problem in the pre-hospital setting. This is a problem in the hospital as well, where um, the needle thoracostomy attempts just don't reach the right space. So there have been a multitude of studies, but in about 30, anywhere from 30 to 94% of the time, that needle decompression is just in the sub-Q space. It doesn't actually reach the pleural cavity. Um, or it's not in the correct position. So that is very, very common. And then there are quite a few cases where patients receive a needle thoracostomy who actually don't have a pneumothorax. And that's because there are a lot of mimics, which we'll talk about in a little bit, the multitude of mimics that can sort of lead you astray. On the sort of converse side, there are a significant proportion of patients who have a tension pneumothorax who didn't receive needle decompression. So on both ends of the spectrum, you can have a patient that needs it and doesn't get it. You have patients who get it, but it's not in the right place. And then you have patients who don't need it at all, but they get an unnecessary procedure. So there are a lot of pitfalls with this procedure. And it's a challenging diagnosis to make. So this was a study that looked at a number of cases in the pre-hospital setting that received needle thoracostomy, and they basically looked at what were the indications that were documented. And in most systems, hypotension is sort of one of your criteria for, a suspected tension pneumothorax. And so in this particular study, only about 8% of patients had hypotension. So a lot of patients receiving it, and the indication that was documented was just reduced breath sounds. That is definitely not an appropriate indication, right? And so I know that that's not really happening here, but I think it can really trip a lot of people up if you've got a sick patient with respiratory distress and decreased breath sounds. But not always an indication for needle thoracostomy. And then the more sort of disturbing finding was that in this particular study, the needle was in the pleural space only about 6% of the time. So 94% of the time it was malpositioned, which is problematic. Um, so I'm going to talk a little bit about technique here. And I forgot to mention initially, part of the reason that I wanted to bring this topic up and have this educational session is that Um, we have had quite a few cases of malpositioning and adverse events related to needle thoracostomies. And so, um, there are cases where the tube ends up in the liver, it's too low, and so that's a problem. So we do want to provide some education around this, and we're going to be putting out something for all of the agencies in general to help educate and remind people of how to do this. But this is kind of a precursor to that. So a little bit a reminder about your technique. And I think recognizing that the pre-hospital environment is very different than the hospital, right? And so I understand that exposing the patient is difficult and lifting the arm may not always be feasible. But in general, if you're taking a lateral approach, you should really try to lift the arm. You really need to lift the arm. And that's because lifting the arm actually decreases the chest wall thickness at that site and makes it so you're more likely to actually reach the pleural cavity. And it sort of makes your landmarks easier to identify. Another point is that you really want to make sure that your needle is perpendicular to the chest wall. So you don't want to go at an oblique angle. And I'm going to show you some very good examples of why the oblique angle is really problematic. Um, you want to go over the superior edge of the rib, and we'll talk about that a little bit later. So you don't want to go underneath the rib, you want to go above the rib. And you never want to hub the device in general. You're really aiming to just get the needle in enough to decompress and then advance your catheter and remove your needle. And some will recommend a needle aspiration technique where basically you take your 10 cc preload saline syringe, you squirt out half of it, you attach that to your angiocath, and then as you're advancing, you withdraw on the saline and you look for the bubbles in the tube. And that probably is a more reliable way to ensure that you're actually in the chest because the rush of air is really not particularly reliable. Um, so I want to talk a little bit about site selection as well. So our two sites are anterior axillary line in a lateral approach, fifth intercostal space, or second intercostal space midclavicular line. Now we in our system advocate for the anterior axillary lateral approach as your first choice. But that's not to say that if the patient's body habitus isn't conducive to that, that you can't do a midclavicular approach. You certainly can. And so you're going to have to use your judgment and base it on what you're seeing in front of you. And we'll talk about the pros and cons of each and why we prefer one over the other. So if you look at this guy, right, he has got huge pectoral muscles. You're going to have a super thick chest wall at the second intercostal space midclavicular line. That's not going to be an ideal spot for this guy. You might not reach his pleural space because his chest wall thickness is multiple centimeters versus your anterior axillary approach, where you're going between the pec, between the latissimus dorsi, and the fifth intercostal space. And you can see you have a very nice shallow cavity there. And so that's going to be a better approach for this guy versus this guy who, he's not going to be easy no matter what you do. And this may not be a successful needle thoracostomy no matter how you approach. But if you look at his body habitus, very thick chest wall at the anterior axillary line, you're probably not going to be successful if you go there. So in him, I would say I'm going to go second intercostal space midclavicular line. I think I'm going to have better luck there. So you kind of have to do whatever you think is right for that patient's injury, for their body habitus, and just kind of use your best judgment. So just a reminder about our site location. Again, lateral, you really need to lift the arm to at least 90 degrees. You need to get the arm out of the way so you can expose your structures and get good visualization. Um, you're going to the anterior axillary line. And I think we see this a lot where a lot of folks will go mid-axillary line. If you look at this picture on the right, you can see that you've got some muscle mass here from the latissimus that you have to go through if you're going mid-axillary. If you go a little bit anterior, you're actually in front of those muscle bellies. And so you're actually in the shallowest space in the anterior axillary. So I would kind of be going like somewhere here in between, a little more anterior. And then you're going to the fourth or fifth intercostal space. I know our protocols say fifth intercostal. You can go a rib space higher, and that's perfectly safe. And some will advocate for that as your primary site. So generally, fourth or fifth intercostal space. For most people, that's going to be the nipple line, or for many people. But again, that's going to depend on your body habitus, right? So nipple in a fit 20-year-old is not the same as nipple in an 80-year-old female. So inframammary fold in females is generally considered better, but it's going to be higher than you think in general. And then what you're looking at here on the left, I think this is just helpful to sort of visualize where those intercostal spaces really are on a human volunteer, right? So you can see that seventh intercostal space is pretty low. But we talk about this triangle of safety, which I'll show you here, which is just a safe place where you're unlikely to damage any structure. So the pectoralis major muscle here is your superior border, latissimus dorsi posteriorly, and then the axilla as well as the fifth intercostal space. So in this general area, you're in a good spot. You can see you kind of have a nice divot there. That's what you're aiming for. Okay, so what about potential complications here? And I think this is a nice graphic, and we'll have this for the midclavicular line as well. But um, the biggest pitfall with the lateral approach is going too low and hitting the liver or spleen, which we have definitely seen multiple times here. So really have to watch out for that. On the left side, even with a lateral approach, you're more likely to have a cardiac or lung injury. So that's also something to be aware of if you're hubbing the needle. And I'll show you some examples of that. Um, so for our anterior placement, again, second intercostal space, midclavicular line, just a reminder of how we find that. So, I mean, you can do this on yourself, but you're feeling for the sternal notch, going down a couple of finger widths, feeling for the sternal angle. That's your second rib. You're going to go just below that. Um, and so finding this site is also quite difficult. And the picture that you're looking at on your right-hand side this was an interesting study where basically they just went to like a national conference and asked people who were off duty to come and identify their landmark on a live volunteer. And the black dots represent what landmarks people identified. And what you can see is that almost every single case, they were lower than they needed to be. In some cases, significantly lower. In some cases, like in the very bottom here, they're really over the cardiac apex, which is really not where you want to go. So 93% of the time they were too low. So it's probably higher than you think, just to be aware. And then a lot of times people will go too lateral or too medial. So making sure that you're in the midclavicular line as well. And if you look at kind of the clavicle here, right, thinking about where mid-clavicle is probably quite a bit more lateral than you might think. So just thinking about that. And then potential complications here, really the biggest worry is that you insert at an oblique angle medially and you go right towards the heart. And so we have some examples of that here. So damage to major vessels or heart is a big one in this. This would be the sort of worst complication. But if your insertion is obliquely in another orientation, you can just completely miss the pleural cavity altogether and have a subcutaneous insertion, which is also not great. Okay, so here's some examples of kind of where things can go wrong if you're not perpendicular to the chest wall. So you can see on the left-hand side here, your orientation is sort of in a downward angle. It's just, you're never going to reach the chest wall because the needle isn't long enough. Again, here we're a little more superior or angled upward, and the needle probably isn't long enough. And then here we're too lateral. So other complications, and this is one that can be very problematic, is intercostal artery laceration. So the intercostal arteries are running, remember, at the inferior aspect of the rib. So if you are going underneath the rib and you sort of angle your needle upwards, you definitely could injure that artery, and they can bleed at a rate of 200 milliliters per minute. So you can certainly bleed out from this and have significant complications. So it's no small thing. So always want to go above the rib, on the superior aspect of the rib as you're inserting. And then liver injury, this is one that we've had some issues with. And so on the left-hand side here, you can see that this was far too low. I think here they are at like the seventh or eighth intercostal space. You can see they're going directly into the liver. But if you actually look at where, this is kind of a nice image, because looking at where the fifth intercostal space is here, you're just barely above the liver, even at the fifth intercostal space. So I think it's helpful to recognize that going a little higher is probably better. And then this is an example of a significant, all this darker area. The liver here is lighter, and then this darker area is all blood. So a liver laceration from a needle decompression. Okay, and then this is kind of the most, probably the most dangerous complication that we can have, and that is a cardiac or great vessel injury. And so these are from a couple of case studies, but I think these pictures represent nicely why the oblique angle really matters. And so this particular needle on the left is, you can see, is oriented very obliquely. So they are really pointing down and towards the heart, and they have almost hubbed that needle. And so what they actually ended up doing was inserting it into the pulmonary artery and causing a cardiac tamponade. And you can see that there is a lot of blood coming out of here. That would be a sign to me that we are not in the right place. Um, and then on the right-hand side, what you can see, and so the bottom image, you're kind of looking up at the patient. You can see kind of his chin here, and you can see that that needle is oriented very medially. You're going basically towards the heart. You really have to be perpendicular. And so this patient had inserted the needle was inserted into his cardiac, or his heart, sorry, his pericardium. So you can see that needle angiocath there. So that's not great, right? So that's just something to be aware of, that oblique orientation is really important. Okay. Then a little bit about chest wall thickness and thoracostomy site and what to look for. So in our protocols, we recommend for peds, we have a 14 gauge angiocath that's an inch and a half long. If you look at the um, average chest wall thickness in a pediatric patient, this is your average patient. And there's not as much variability in kids as there is in adults, because we know in adults we've got huge variation in sizes of patients. But in kids, it's a little more uniform. They tend to have less variation in chest wall thickness. They're going to be about 1.6 to 2.5 centimeters. And so if you look at where that is in relation to your angiocath, and this is roughly to scale, you're roughly inserting that about half to two-thirds of the way into the chest to get into the pleural space. And typically speaking, in most patients, the mid-clavicular approach at second intercostal space, your chest wall thickness is actually thicker there, which to me was a little bit surprising, but that's thicker than your fifth intercostal space anterior axillary. In adults, again, much more variability in chest wall thickness in the adult patient. But if you look at, in our system, we recommend a 3.5 inch 10 gauge angiocath. So that's a little over 8 centimeters. And if you look at the chest wall thickness of the average adult, this blue box is where you will land to get into the pleural space. So you can imagine that if you're hubbing it, you're getting quite a bit of distance into the chest cavity, and can cause some damage. So just be aware of that when you're looking at your patient. Again, you're not going to know their chest wall thickness, but it is a consideration. Like hubbing it is generally not indicated for most people. Okay. All right. So, and one of the things I hope that people take away, I think sometimes in our system we get this idea that we recommend the anterior axillary line. That's your first line approach, and if you do the midclavicular second intercostal space, you're going to get a QI or you're going to get in trouble. That's not the case, right? You have the choice of these two sites, and just use your common sense or critical thinking and think about what would be best for this patient. And it's perfectly acceptable to do either site. Just document why you did it, right? So there are reasons why the fifth intercostal space is better. It's or more challenging. Generally speaking, the chest wall thickness is less, so it's probably going to be better in your very obese patients if you can access that site more easily, if it looks like a good site. The injury rate is going to be higher at the fifth intercostal space. The tube is more likely to get dislodged, so you got to watch it a little more carefully. It's more difficult to get to that spot, right? You have to lift the arm, you have to completely disrobe the patient and really get in there. Whereas the second intercostal space midclavicular line, easier to locate. I think your landmarks are a little more clear, a little less variable between patients. And your, you know, your obese patients, it's not going to be the greatest for. But if you have a thin patient and you can get your landmarks better, that might be a better approach. It just depends on the patient and their illness. Another consideration is your pregnant females greater than 20 weeks. Remember, obviously, in pregnancy, you've got a lot going on, and the uterus is pushing the abdominal contents up into the chest cavity. And so the in pregnant females greater than 20 weeks, we generally recommend going to a rib space above, so the third intercostal space anterior axillary line, or a midclavicular approach in the second intercostal space. So you're going to have to go higher to avoid intra-abdominal injury in the very gravid pregnant patients. Okay, and then there we recommend pretty long needles in our system. There's a lot of debate out there about what the ideal needle length is, and some would say bigger is better, and it's true that the longer your needle is, the more likely you are to reach the pleural space with it. So this was a study that looked at needle length and failure rate with decompression. And so you can see that with a shorter needle length, which is up here on the left, you have a very high failure rate. And as you reach 8 centimeters, your failure rate is much lower. So you're much more likely to get into the chest wall. But longer needle means more injuries. So here we're looking at needle length on the left and increasing towards the right. And you can see that our injury rate increases precipitously as you get up into 8 and 10 centimeter needle lengths. And so we have, in adult patients, we recommend a little over 8 centimeters is our needle length. And so we are approaching that territory where we potentially could have more injuries. So it's a balance, and I think it's just being aware that there is that possibility, and the longer your needle is, the more likely you're to damage underlying structures. So, and then how do we confirm decompression? It turns out it's not very easy, right? Because we can't even be sure that this patient actually has a pneumothorax. So it is a difficult thing to know, like, do we expect a rush of air? Are we in the space? Um, I think probably the biggest thing to look for is clinical improvement. So we expect that if we truly had tension physiology and we are in the pleural space, we should see some clinical improvement. The rush of air is really not reliable, but you should see hopefully some improvement in hypoxia, improvement in respiratory effort, maybe improvement in breath sounds. But again, clinical improvement alone is also confounded, right? Because these patients are often going to have hemorrhagic shock on top of everything else. So this is a really difficult thing to confirm. There are devices out there that you can use to help confirm placement. This is one example. This is a colorimetric and tidal CO2 device that attaches to the needle and gives you color change if you're in the pleural space. So I think that's pretty nifty. These devices are expensive, so I don't anticipate that any agencies are going to jump on getting these because they are expensive. But can help you identify whether you are in the right space. But again, this is challenging because maybe the patient doesn't actually have a pneumothorax. So, you may not expect to see a color change and if they don't have an actual a pneumothorax there. So, a little bit challenging. This isn't a swine study, but they basically looked at did these animal models have improvement with needle thoracostomy? Did they have failure of the insertion? And basically the long and short of it is that kinking is common and obstruction is common. And it's common within the early phases of decompression. So because the tubes, while we use a 10 gauge tube, so I think we have less issues with that. With like a 14 gauge angiocatheter, certainly um, uh, kinking and obstruction is really common. Um, and then oftentimes even the tube just doesn't really relieve the tension physiology. So the tube may not be large enough in some cases. Okay, so swinging back to our case, we're almost we'll probably finish a little bit early, but so this patient, this is his chest X-ray, and what you're looking at here is this is his diaphragm. Those red arrows are pointing to the diaphragm of the patient, and what this is something external to the patient here, this like weird oblong thing, but this is his stomach up in his chest cavity. So this patient had a traumatic diaphragmatic rupture with a gastrothorax, which is an absolute contraindication to needle thoracostomy. um, Difficult thing to identify in the field. You can. And so what you would listen for is stomach sounds over the chest. And I've actually, that's the only time I've seen this. You could very audibly hear the rumbling stomach when you listen to chest to breath sounds. And so that would be an indication that you probably have um, a gastrothorax. And so you don't want to stick a needle in that. Um, Okay, really briefly, this traumatic diaphragmatic injury, very uncommon. Most commonly, when it occurs, it's left-sided. And these patients often will have a delayed presentation. This is something that actually they can have a diaphragm injury that doesn't present initially, and then many years down the line can have complications from it. But if you have a big enough laceration through the diaphragm, you can definitely present acutely with a diaphragmatic rupture. And a lot of these patients actually also have an associated hemo or pneumothorax as well. This is an example of a right-sided diaphragmatic injury. And you can see that the liver is actually herniated through the diaphragm into the right chest. And really the reason that you don't see it on the right side is that the liver is kind of protecting that hemidiaphragm. And even if there was an injury there, it doesn't often lead to um, uh, herniation of the contents into the right chest wall, just because the liver is so large. This particular patient ended up having a multitude of injuries, but it was a 15 centimeter diaphragmatic injury, so pretty big injury. Um, underwent repair and was discharged subsequently on hospital day 6. No complications from the needle thoracostomy in this case, thank goodness. So he did okay. And then one brief additional case here. So this is our second case is a 55-year-old female. She has a history of cystic fibrosis, which is a genetic condition that predisposes patients to infections. And these patients typically will, at least historically, have died at a much younger age. But as we're seeing some advances in medical care, they are living to be older. So in this case, this was unique because this patient is much older and living with cystic fibrosis. But in any case, she was outside. Her husband heard her cry out, found her unconscious and bleeding from the mouth. So no preceding symptoms, kind of just collapsed outside. And she's otherwise pretty healthy. So these are her initial vital signs. Her SATs are just garbage. Her blood pressure is borderline. She has diminished breath sounds on the left side, very altered, but moving her extremities with painful stimulus, but very, very sick. Okay. So this is her initial waveform. So what you're looking at here is just like a readout of the monitor strip. So this is the actual strip. And you can see the SpO2 waveform. We don't have a reading on here, but it was low, but she did have a waveform with it. They ended up intubating the patient with the tube was at 21 at the teeth. And after intubation, they noted that she still had decreased breath sounds, so those did not improve. And her stats just continually declined. So the best they could get was in the 80s, and they continued to get worse and worse. So, given the decreased breath sounds and the hypoxia and her borderline blood pressure, very astutely, they considered, could this be a pneumothorax? They actually did consider mainstem intubation, which was the right thing to consider. They pulled the tube back a couple centimeters with no improvement. And so they decided to go ahead and do a needle decompression on the chest. Um, so they went ahead and did that, and the SATs just did not improve. The patient continued to decline. When she arrived at the hospital, of course, they were able to get their chest X-ray. It looked like she ended up having an infectious process in the lungs. And what they found was that she had massive bleeding from her endotracheal tube that eventually sort of manifested. And it turns out that that infection had eroded into one of the arteries in the bronchus, and she had hemoptysis. She had massive hemoptysis, and she had big clots that were obstructing the airways. So she didn't have a pneumothorax at all, the cause for her decreased breath sound was she had no air entry because there were clots in her bronchi. Um, so, another sort of mimic, another pitfall, right? So I think in that case, I think it was a reasonable assumption to think, could this be a pneumothorax? And I actually think it was reasonable to attempt decompression in her case because, she had kind of all the signs, but um, ultimately it ended up being a hemoptysis issue. She ended up expiring during her hospital stay, unfortunately, but um, so, just to say that there are a lot of mimics out there, and so it's exceedingly difficult in the pre-hospital setting, and sometimes even in the hospital, in your initial assessment to determine what exactly is going on with those decreased breath sounds. So, really briefly on massive hemoptysis, this is typically defined as coughing up more than, I think it's 200 or 250 cc's. Now the exact number is escaping me, but not a huge volume, 200 cc's. But massive hemoptysis is about 200 cc's of blood in a 24-hour period. Lots of risk factors, including lung cancer, tuberculosis, cystic fibrosis, other chronic lung conditions. Um, and the way that we manage these patients is a little bit different. So if you have to intubate somebody with massive hemoptysis, the general recommendation, and this is a consideration if you have one of these patients, sometimes it will be obvious that they're coughing up a lot of blood. And so you want to use the largest tube possible. And so I might reach for, if I think that their airway can accommodate it, I might reach for an 8O tube. And that's because you want to be able to get to remove clots that might develop, but also those patients need a bronchoscopy. And so if you have a larger tube, you can actually accommodate the camera that they use to put down to intervene on that uh, uh, bleeding airway. So they will put a camera down and then actually go in and try to embolize or fix whatever the issue is that they're seeing. Um, Another thing is that you can sort of selectively ventilate the patient. So you want to put the bad lung down so that they can sort of preferentially ventilate the good side, at least. That's, probably not going to make a huge difference, but it's one of the few things that we can do. In the hospital, sometimes we'll use nebulized TXA for these patients. So we'll actually just put the TXA in a neb and try to help with the bleeding that way. And that would be somebody who is not needing emergent airway management, but has a lesser degree of hemoptysis. Okay. So just a quick, the list of pneumothorax mimics, both of these cases were actually kind of mimics, and there are many, many others that can really lead you astray. This happens in the hospital where we sort of get mixed up all the time as well, so it's not uncommon. We have the advantage of having ultrasound and chest x-ray and all of those diagnostic modalities. So I know it's much more difficult in the pre-hospital setting. But one of the things that you really don't want to miss as a cause for decreased breath sound is that main stem intubation, and we definitely have seen that as well. Okay, so key points, the takeaway is what you do matters, your technique matters. So remembering all of those, lifting the arm, being perpendicular, don't hub the needle. Your site location matters, and you have discretion to go where you think is most appropriate. Again, in most patients, that's going to be the fifth intercostal space anterior axillary line, but you can use your judgment. And if you feel like the second intercostal space is better, that's perfectly fine. Just make sure you're perpendicular in your placement, and then your indications matter. So that's all I've got for today. I will open it up for any questions or comments. And your CE code is here as well. Excuse me. Another point that when the NAMSP, the National Association of EMS Physicians, they put out a lot of guidelines around pre-hospital care and stuff. And in their recent paper last year, they did have some discussion around open pneumothoraces and occlusive dressings and how to manage that. And this is something that we may need to look at with our guidelines, but basically in spontaneously breathing patients, putting an occlusive dressing on, or really where they would recommend a chest seal with a one-way valve is the preferred. But if in the absence of that, doing just a thin adherent dressing like a Xeroform or I'm blanking on the name. Basically, a thin occlusive dressing is fine, but in patients that are receiving mechanical ventilations who have an open pneumothorax, generally speaking, occlusive dressing or chest seal is contraindicated just because you can actually precipitate a tension pneumothorax because you are getting that positive pressure throughout the respiratory cycle and it fills the pleural cavity much more quickly. So just something to think about. No longer recommending three-sided dressing. So that is officially the word. But anyway, that is all I have. So if there are no questions, I'll stay on for a little bit longer. Happy to answer any questions about this or anything else. I'm gonna stop recording for now.